Hi there, I'm 𝗲𝗿 𝗟𝗏. I've been a licensed Medicare insurance broker for 25 years, and today, hot off the press, we have more information about Medicare and Medicare Advantage as it may pertain to you or someone that you know or love that is considering what should they do for their Medicare insurance plan. These plans in the news, it changes all the time, and that's why I've been educating people. 5 million viewers now so far on YouTube. Thanks for being one of them and watching. If you haven't yet subscribed, I encourage you to do so if you care about Medicare half as much as I do. Our agency is based in Charleston, South Carolina. We work over the telephone, helping people in all 50 states in the United States with their Medicare insurance, and we're one of the best out there in my own humble personal opinion. Today in the news, something actually that just kind of blew me away, but I'll leave my personal opinion out of it, and I'll just read to you the news. From CVS, the Office of Inspector General with Medicare is conducting an audit of Aetna's Medicare Advantage plans. This came out August 5th, 2021, late in the afternoon. Today, in fact, that is today. Department of Health and Human Services Office of Inspector General is taking a closer look at Aetna's Medicare Advantage plans. The Department of Health and Human Services is putting Aetna's Medicare Advantage plans under the microscope, the insurer's parent company, CVS, disclosed on Wednesday. It's today. CVS said in the Securities and Exchange Commission filing that the OIG is taking a closer look at the insured's risk adjustment related data. Other insurers, including Anthem and Humana, have come under similar scrutiny. There has been a significant push to take a closer look at how insurers are submitting such data as the program grows in popularity and profitability. Quote, the company expects CMS and the OIG to continue these types of audits, CVS said in the filing. If you're not familiar, CVS owns Aetna. Earlier this year, the Fed said a Florida Humana plan overcharged Medicare by more than $200 million, the largest audit penalty ever posed to an Medicare Advantage plan. Shortly thereafter, the Office of Inspector General said Medicare overpaid Anthem in Massachusetts by $3.5 million. Medicare Advantage payments are calculated based on a regional factor and spending in fee-for-service Medicare. So the government pays Medicare Advantage plans for members with higher acuity needs like chronic conditions. Critics allege, and stay tuned for the next story right after this one, same point and also came out today, critics allege that insurers will add unneeded codes to otherwise inflate their risk scores in order to boost payouts from the government. Medicare Advantage plans, meanwhile, argue that the Office of Inspector General uses flawed methodology to measure overpayments as it bases its analysis on just a small sample. In the case of Anthem, for example, the OIG extrapolated overall payouts from a sample of $354,000 in inappropriate payments. CVS flagged the audit as part of its quarterly earnings report released Wednesday morning. Now, also just came out in the news, you may have heard about this if you follow Medicare, if you're subscribed to the Medicare website's updates and their press rooms and all that. It's stuff that I do on a daily basis. It's kind of weird. But what came out a couple of weeks ago was CMS is actually asking for your input, the public. They want your commentary on what you think would make Medicare Advantage better. Now, many people will respond, just get Joe Namath off my stinking television, and I would applaud you for that comment. But they're looking for more in-depth commentary. They're looking for you to share ideas on how you can improve, how they can improve the delivery of Medicare health care through Medicare Advantage. Now, remember, if you're not familiar, Medicare Advantage is only one way that you can get your insurance as a senior. You could go original Medicare, which you've paid into and earned your whole life. And original Medicare is really great insurance. Couple that with a supplement or Medigap plan, and it fills the gaps, leaving you with great insurance with no major gaps in it. That's one way to go. That's the traditional way. Medicare Advantage is when you're basically opting out of the Medicare system, and a private entity, an insurance company, a for-profit, usually a stock company, is making profit based on the difference between how much they're paid by the government and how much they pay out in health care. They're paid this, they pay out that, and that difference between those two hands of mine, that's the profit. And the profits are really up. So I want to read to you something from someone on the inside. This is insider information, but it's extrapolated, love that word from the last article, from someone writing in on the commentary as requested by CMS. They're asking for the public to tell them what would make Medicare Advantage better, so somebody replied. Now this is in Recovery Audit Contractors Monitor, RAC Monitor. It's an online publication. The author of this article, this letter, is 𝗲𝗂𝗃 𝗟𝗂𝗃, registered nurse, master and nurses, CCM and UM, which I don't know what those designations stand for. But it says, a reader responds to the CMS request for feedback on ways to strengthen Medicare Advantage plans. The title is Medicare Advantage Plans, a Disadvantage to Patients and Providers. As a seasoned utilization management nurse of more than 20 years, there's some credibility for you, who has worked on both the payer and provider sides of the industry, I've never before seen or experienced the diligence that Medicare Advantage plans have exercised this year to find loopholes and ways to misinterpret Medicare language to their advantage and to the disadvantage of Medicare members and providers. Here are just a few examples. One of the largest Medicare Advantage plans in the state of Michigan this year informed hospitals that they can take up to 14 days to make a decision to approve or deny an inpatient admission because CMS, which is Medicare, does not define an inpatient admission authorization request as pre-service. Therefore, once the patient is in a bed, it is considered post-service, and CMS allows Medicare Advantage plans 14 days to make a decision on a post-service request for prior authorization. With national average length of stay for inpatient admissions at 4.6 to 5 days, this means that many Medicare patients, Medicare Advantage patients, let's be clear, will be discharged without knowing whether their inpatient admission was approved or not. How is this consistent with CMS guidelines that patients should be notified as expeditiously as possible of their admission status? Number two, the same Medicare Advantage plan has published in their provider manual that they do not follow the 2 midnight rule because they have documentation that CMS, Medicare, said that they don't have to. Consequently, patients can be in observation for greater than 48 hours, and unless the patient meets the 𝗃𝗂𝗿 criteria on day 3, chances are that the patient's stay will be denied by the Medicare Advantage company. I added Medicare Advantage company because that's what we're talking about. That's the context. Medicare Advantage plans insist that the 2 midnight rule is not a Medicare rule and that the Medicare Advantage plan decision not to follow the rule is not being more restrictive than Medicare. If the 2 midnight rule was established as part of the CMS Ops final review in 2013, as it was, why do Medicare Advantage plans say it's not a Medicare rule? I'll tell you why. It's because Medicare Advantage have different rules than original Medicare. And all the sales material that they tell us to tell people in our training every year, certification, says that they have to cover the same things. No, they don't. They have to cover the same categories of things. They can and routinely do deny your care. See the OIG video about that very topic. So, when a patient has to stay in observation status beyond a medically necessary second midnight and be responsible for higher copays and payment for drugs that can be self-administered, isn't the Medicare Advantage rule more restrictive and more of a disadvantage to both the patient and the hospital? Isn't Medicare's definition of inpatient based on the 2 midnight rule? So how is the Medicare Advantage plan are allowed to have their own definition of what is an inpatient on a Medicare patient, and such definition being based solely on their criteria? Number 3, CMS has never endorsed specific criteria to be used for determining whether a hospital admission is appropriate for payment as inpatient or observation, primarily because CMS definition of inpatient is based on the 2 midnight rule, and the decision being complex medical judgment which can be made only after the physician has considered a number of factors, quote unquote. Medicare Advantage plans are notorious for denying inpatient admissions based strictly on 𝗍𝗂𝗿 or MCG criteria. When asked why, and the Medicare Advantage plan stated that they are complying with CMS requirements to use, quote, nationally recognized standards, i.e. 𝗍𝗂𝗿. However, these 2 most popular criteria do not allow individual patient medical history and current medical needs, the types of facilities available to inpatients and outpatients, the hospital's bylaws, admissions policies, and relative appropriateness of treatment in each setting, which are all the Medicare definition of inpatient. In addition, Medicare Advantage plans apparently are allowed to establish their own criteria, such as short stay lists, based solely on diagnosis or length of stay. Another one. Another large Medicare Advantage plan in Michigan has recently implemented a policy that forces observation status on patients whose LOS in the hospital, length of stay, is less than 48 hours, regardless of the patient's diagnosis, comorbidities, special circumstances, or attending physician's decision. Don't listen to the decision of the doctor. The only exceptions to this Medicare Advantage plan's observation policy is if the patient dies, or leaves against medical advice, or elects hospice, or transfers to another acute care facility. How is this Medicare Advantage plan forced observation policy not being more restrictive than Medicare? And how is this health plan's definition of an inpatient consistent at all with Medicare's definition? Medicare Advantage plans, she goes on, are indeed taking advantage of Medicare, primarily through interpretation of either CMS language that is not clear, or misinterpreting language that is clear, but which they can use to their advantage, no pun intended. The administrative burden of hospital providers in establishing process workflows just to be able to cope with Medicare Advantage plan rules and requirements is tremendous. When a Medicare Advantage plan posts billions of dollars in profit year after year, while smaller hospitals close because of lack of resources, to fight the abuse by Medicare Advantage plans, her words, not mine, and she works in this field. Shouldn't CMS pay attention and a closer look at what is really happening on the front lines of the industry? The need for more intense scrutiny of Medicare Advantage plan practices, established clear guidelines for both payers and providers through transparent communication, and more stringent audits to ensure consistency between Medicare Advantage plan rules and CMS guidelines appear to be warranted. Almost the same exact thing that the Office of Inspector General said early in 2022 and in 2019. They're making up their own rules and not what Medicare's rules are for when they deny services. Several Medicare Advantage plans have even dropped their NCQA accreditation for their Medicare product lines, quote, because there is no regulation by CMS requiring accreditation. And more importantly, accreditation standards appear more stringent than CMS. They're just not getting accredited anymore. As a Medicare patient, she writes, I will never encourage friends or family to sign up for a Medicare Advantage plan. Medicare Advantage plans have great enticing advertisements of extra or supplemental benefits. What Medicare patients do not know or realize is if the current challenges that Medicare providers must endure continue, more hospitals may close. More practitioners may not want to participate in Medicare, and Medicare patients will end up paying more out-of-pocket costs. In the bigger picture, Medicare members may lose the care they need and deserve. Wow. So that's one person's opinion, and I encourage you, if you have any stories at all about your experience with your family or you on one of these types of plans, please leave it in the comments below. And if you're willing to, you can contact my office. There's a reporter doing a story and compiling these things, and she's quite amazing. And we have compiled over the years hundreds, if not thousands, of stories, not just through the comments, but in our conversations with seniors that we've helped from Virginia to California and everywhere in between across this country. And we've helped put people into different plans. The thing that breaks my heart, that challenges me the most, is when we come across somebody that we can no longer help. See, the reality is when you're turning 65 or you're brand new to Medicare because you're leaving an employer plan at different times in life, when you're new to Medicare, you have a major choice then. Your major choice is you are in your initial election period. You can go to any one you want to go to. Follow me here. You can go on original Medicare and get a Medigap plan, Medicare supplement, which covers everything that's medically necessary covered by Medicare at any provider that accepts original Medicare, which is most in the entire country. That's one way to go. Your doctor decides what's going to be treated and covered right then. Or, and that's the one you paid for your whole life, by the way. That's traditional Medicare, been around for decades. Or you can go Medicare Advantage, and they decide what health care is appropriate for you, what doctor you get it from, which ones require prior authorization or not, and which ones they're going to apparently retroactively go back and deny, maybe. of these two choices. Medicare Advantage plans you can do any year you want to. There is an open enrollment period. It's the annual election period, the technical term. Every year from October 15th through December 7th, you make that choice if you want to, and it kicks in January 1st. And it'll run that entire year from January 1st to December 31st of that next year. Those plans change every single year. What's inside changes, the copays change, the networks can change, the benefits change, the drugs change that are covered. Those plans just change every year, and it's a nonstop game of musical chairs as to what are you going to get next year or which plan are you going to hop to. Meanwhile, that original choice, the road now less traveled, is original Medicare that you paid into your whole working life, a Medicare supplement plan that by law cannot change. They can't take it away from you. It can't change unless one thing happens. You either die or you fail to pay the premium on that insurance plan. They can never, ever, ever take it away from you. The challenge is this. If you don't get it during your initial election period, when you're eligible for any of the plans without any question, without any underwriting, without any health questions whatsoever, you may never then be able to upgrade to that type of plan ever again. Why? Because in most all states, to go on those plans after your past 6 months of your initial election period's over, let's say you start on Medicare January 1st. Well, when July, August, and September arrive, it's too late to go back and get one of those plans unless you go through health questions. One of the reasons I'm so proud of my agency is we are very good at the health questions. We know what's involved to get you approved for those plans, but unfortunately, and what happened again today, which is what drives me to tell you this news, is we had another person call in today. They're on a Medicare Advantage plan, and now they're going through all the steps of paying copay, admission, copay, hitting thousands of dollars out of pocket for a free plan they were told was free, no premiums due whatsoever, and it's killing them, it's crushing them because they're a heavy user of healthcare. And when they turned 65, they said, I was healthy as a horse, didn't need anything. Well, do we get easier to take care of or harder to take care of the older that we get? Let's be honest, really? So the problem with this person is now they want to go to original Medicare with a Medicare supplement plan. And once you have a chronic condition, once you're using a wheelchair, cane, or walker, or you've got diabetes with complications, or you've got all these things, you've had major heart issues, you've got things that are so common nowadays, that's when you can't any longer get, that's a double negative, you can no longer obtain a Medicare supplement plan. Yes, we can do the best we can shop the market, we can look at everybody's health questions and the criteria, and we know what those are. We can help with that. But I'm telling you, to have the run of the field to get whichever one you want, you have to make the right decision when you're turning 65. That's why it's important to find a trusted broker, somebody who knows what the heck they're doing, cares about seniors enough to tell you the truth. And we're going to show you both ways. I'll tell you right now, we'll show you what this way is, we'll show you what that way is, but we're going to be honest about telling you the fact that we make more than double the commission on one of them than we do the other, because I believe in full transparency, and I've said it a million times on this channel, and I'll continue to say it. We as agents make more money to push the free plans that the government wants to get you off original Medicare and put you on the Advantage plans where they'll manage your health care. It's a fact. But if that's the way you want to go, we can do it for you. Just go to somebody you trust. If it's not me, if you won't listen to our advice, you won't take the information we've given you, that's fine. Just make sure you go to somebody who's going to be in the business and going to be accountable to you going forward. And the worst thing you can possibly do, and I'm not saying this for my benefit, you can go to anybody out there that you trust. The worst thing you can possibly do is get something in the mail, spend 10 seconds reviewing that, and then go make a decision that's going to impact the rest of your life on Medicare. Based on something you saw in the mail. Oh, I get free dental. Woohoo! I get free glasses. I get a free trip. I get a free air conditioner. I get free this. Really? How does that really work when the rubber meets the road? Why don't you call a broker that has more than 10,000 experiences of dealing with plans just like that, can tell you the truth, can tell you what's going on today in the world of Medicare. That's what my office does every day. Oh, and by the way, it doesn't cost you a dime to use a broker. It doesn't cost you a dime. It's the same plans, it's the same premium, it's the same things available to you, but with context first to explain it to you, and with accountability to be there to back it up afterwards. So if you want both sides of the story, you want somebody to be honest and tell you what's really up, then please call my office. The number is 800-729-9590. 800-729-9590. 9590. I'm Christopher Westphal. Thanks so much for watching. God bless you. Stay safe. And if we can help you in any way, please reach out. Bye-bye.